Lovely, thank you. Ladies and gentlemen, welcome to today's discussion, which is quite interesting given the, recent LEN-PrEP that we've just received, which is a very good sign on the fight against HIV/AIDS, especially in the African continent. But it also is exciting because you only have to take it twice a year. But as we know, when it comes to LEN, there's a lot of misconception and misinformation that is circulating. But we also want to have that discussion around community considerations in programming for LEN-PrEP, just giving it a clear focus on what the Global Fund is also doing. I'm your host, I'm Ms. Lizzie Otai. We've bumped into other discussions before, but I'm a communications consultant. And today I'm going to try and make this as interesting because we have received a couple of questions around LEN-PrEP. And we also want to kind of answer those questions as per the discussion that we're going to have in this amazing lineup of speakers that we have right now. As I mentioned, this is going to only last an hour and a half, so we're trying to make sure we get the most out of it. And we're just projecting the brief agenda for today on how it's all going to pan out within the hour and a half. Next slide, please. Yes, Rui, I'm assuming I'm very fast. We do have translation. I will try and be slow, Rui. Yeah. Um, Let me see. Maria, can you hear me or is it the same case?
I can hear you fine. However,
Yes.
I'm not seeing a translation or interpretation.
In the translation room. Yes.
Yeah, I've gone to English and I can still hear you.
Okay, perfect. Rui, maybe it's a matter of internet. Maybe try another one, but in case it gets worse, do let me know. Great, thank you. Ladies and gentlemen, that's Rui. He's translating the ongoing session that's purely run in English into Portuguese. And as I mentioned, an hour and a half is not enough to even start discussing LEN-PrEP, but the agenda will just kind of make it a little bit light so that we create enough time for Q&A. We're going to set the scene, which is actually what I'm doing right now, and then we just frame the whole session, try to understand what LEN-PrEP is, and of course, the reason why we always do this is bring in community priorities and learning exchange so that we get to hear what's happening on ground, but also open it up and have an interactive dialogue with communities and CSOs present, because we know you've already started having, getting involved within the LEN-PrEP area. Next, please. Well, the usual, this is just us to make sure that we're on the same page. Our webinar housekeeping rules are really very simple. You'll be muted, so when you want to actually ask a question or give in your input, I recommend you use the electronic hand. Of course, be on mute so that we can make sure we hear each other. Rename your account because we'd want to address you with the name that you would prefer. And of course, as so under the Anglophone Africa Regional Learning Hub that we're hosting for the Global Fund, we always want you to network. So please feel free to use the chat option, introduce yourself, leave your contacts there, and let's just network and network. And of course, one rule for ours is always respecting each other's opinion and inputs. So yes, let's start off the discussion. As I mentioned, next slide, please. As I mentioned, we're talking about LEN-PrEP. A lot of questions have come in. We do have our partners and experienced community experts who are going to let us know what's going on. But before we kick off, we'd like to start this discussion by just understanding LEN-PrEP in Global Fund supported programs. And we do have Maria on the call. Maria is like Senior Technical Advisor, Key Population from the Global Fund. We're super excited because we do want to start this discussion without knowing where the Global Fund stands. And of course, they've also kind of started purchasing it. And this means we are getting the same PrEP at the same time that the developed countries are actually receiving the same. So this is groundbreaking. This is actually quite amazing. We're not competing this time around or waiting for it. We're getting it. We're getting the access on PrEP at the same time, which is amazing. So Maria, over to you. It will be good for you to actually help us understand what the discussions are going to look like today.
Thanks so much, Lizzie, and great to see so many familiar faces and also some new names. So myself and my colleague Chris from the Global Fund, Chris Obermeyer, will be here today to kick us off with the discussion. And Lizzie, I really think you covered everything in terms of opening remarks. We're really here to hear a bit more about what LEN-PrEP is, to indeed perhaps demystify some of the story around LEN-PrEP, what it is, what it isn't, what it can and can't do, and why it's an exciting new addition to the HIV prevention toolkit. As ever, Chris and I always frame all of our discussion around this new innovation and this exciting new innovation in the overall framework that we are also talking about prevention in general. So this is an addition to the toolkit. It's not the only tool. We remain fully committed to HIV prevention, and all the products that folks might need. Choices remains critical and extremely important in this conversation. But for the purposes of today, we will be talking specifically about lenacapavir for PrEP, the potential, why it's a priority, and what it is. Then we're really looking forward to hearing from you, as Lizzie mentioned, in terms of lessons learned and best practice in relation to community engagement systems and responses in relation to prevention products and PrEP. We're looking forward to hearing about the different aspects of the introduction of a new product. This could be everything from developing policies, plans and budgets, preparing platforms and service delivery arrangements, supporting uptake and use, and monitoring and evaluation and learning, and some of the key areas within that communities are really leading the way in terms of engaging in technical working groups, in terms of shaping policies and at national level, in terms of delivering services, offering peer-led services, for example, also monitoring evaluation. So, for example, adapting CLM to incorporate LEN for PrEP is an interesting area. So that's the kind of framing of today. And with that, shall I hand straight to Chris? Lizzie, for the next session, he's going to kick us off with
Yes, please.
LEN. Chris, over to you. I'll share after.
Great, thank you so much. Hi, everyone. I'm really happy to see a few familiar names and a lot of new names. So to start us off today, I just want to make sure we all kind of have an overview of what lenacapavir is, more than just knowing that it's, twice a year. I want us to go a bit deeper and further understand the product. And I also want to hear from you all. So during this discussion, you will need access to the chat, and I'll tell you when, just to make this a bit more interactive rather than me just like talking at you. Next slide. There we go. Great. So lenacapavir, it's a 6-month injectable PrEP. As we all know, it's been really successful in clinical trials, which is really exciting, showing up to 100% success in preventing new infections. As opposed to oral PrEP, as opposed to cabotegravir, the ring, other PrEP products, it has longer dosing, being every 6 months. And so it might be a more convenient option for people. So it's going to mean fewer HIV tests. It's going to mean fewer visits to wherever you're getting your PrEP. It's going to mean you don't have to worry about forgetting an injection every 2 months, or changing your ring every month, or taking a regular pill, right? To maximize the impact of lenacapavir, it's really important that the programs are designed to drive access to those who have the highest HIV incidence in a country or in a setting, while still making sure that anyone who wants lenacapavir can have access to it. What this might look like is maybe in a certain setting, adolescent girls and young women are disproportionately affected by HIV. And so when the program is being designed, ideally you're looking at how do we reach AGYW, right? However, if that design means that lenacapavir is available in a family planning clinic, for example, we want to make sure that if someone else who is maybe not AGYW walks in and wants access to lenacapavir, they probably need it. And so making sure that they still have access to it. We know from oral PrEP, probably and other products in probably every country represented here today, that saying only certain people have access actually is stigmatizing and create challenges and barriers to access. So that's really important. In July, WHO made the recommendation that lenacapavir be added as an additional prevention option for people who need it as part of combination prevention approaches. So we know that there's lots of different HIV prevention options. Next slide. As I get into more of the details, I encourage you to put questions in the chat. I'll try to answer some of the technical pieces so we have more time as we go along. But if those come, it's really helpful. So I encourage you to do that. So as Maria pointed out and kind of in the introduction, the reason why we're excited about lenacapavir for PrEP is that it's going to expand HIV prevention choices and coverage. I want to pause this. I think that maybe okay. I know the interpreter, if you need me to slow down, please tell me in the chat. I will try to be more conscious of that too. Yeah, great. Feel free to raise your hand if I'm speaking too quickly again. So what we want to do is we don't want to see that lenacapavir replaces approaches that are already working for an individual. So if someone has no problem working and using condoms, that's great. Continue to use condoms if that's your preferred HIV prevention method. Lots of people prefer them. It prevents unwanted pregnancies. It prevents other STIs. It's a really, really great option. For people who like oral PrEP, me being one of those people, because I don't have a problem taking a pill every day. I can remember to take it. That's not a challenge. I take other pills, so it's great. That's great. Maybe I don't want to choose lenacapavir because I don't want to have to go to the clinic every 2, or actually I'm afraid of needles. So maybe I don't want to use it for that reason. For other people, they really like the ring because it's discreet. They can use it. Not everyone knows about it. They maybe like that there's no real worries about other drug resistance. It's a great product for them because it's discreet, doesn't involve injections. Other people are going to prefer injections, whether it lasts 2 months or 6 months. And so our goal in expanding the HIV prevention toolkit is that as more tools become available, people can choose which thing fits their life for the moment that they're in. For some people, that might be oral PrEP for a season. It might be the ring for a season. It might be injectable. They might go back to oral options. We want people to be able to have those options to be able to adapt the product to their life rather than their life to the product. Next slide. So I want this group to look at these options. And I want you to imagine you need PrEP. Maybe that's real, maybe it's not. But here are the 4 options that WHO has recommended today. And I want you to put in the chat which one you prefer based on whatever factors you want to think about. So do you prefer oral PrEP, which
Technology,
for a
even
lot of
if
people
it is not
requires them
necessarily
to take
better.
it daily? Some people can use it event-driven. Do you prefer a vaginal ring that is inserted? And right now, the only one that we have available is monthly. Do you prefer cabotegravir, which is a 2-month injection, 2-monthly injection? Or do you prefer lenacapavir for PrEP, which is a 6-monthly injection? You can see that the efficacy is different for each of these products. And so I'm curious if people can put in the chat, you can put A, B, C, or D. You can write lenacapavir, you can write cabotegravir, you can write the ring, whichever you prefer. But I want to hear some people's ideas of what they choose. I see 3 for lenacapavir already. Someone saying oral PrEP. Lenacapavir again. Another oral PrEP, another oral PrEP. And I think that if we had more time today, I could probably ask each individual person, and every single person would probably have a different reason for choosing that, right? So for me, I already said right now, oral PrEP is great for me. I am kind of curious about lenacapavir. I'm curious about what it feels like. Maybe I would want to try it, but I would want to be able to, have the option, maybe go back to oral PrEP if I didn't like it. V, which makes cabotegravir, is working on longer acting products. So I'm kind of curious about that as well. A lot of people are going to have different things, right? And You know, if Gilead comes out with an annual lenacapavir, which is something they're working on, I might be less afraid of needles if it's something that I just do once a year. So there's lots of things that we all consider, right? If maybe I had a partner at home that I was worried about seeing my PrEP use, I probably wouldn't choose oral PrEP because I probably would hide the pills and I would not remember to take them, which we know happens a lot. And I see someone's curious about the ring and how that would work, right? So everyone's going to have a different decision. Just like if I asked everyone, what is your ideal breakfast option? You would probably all choose different things for different reasons. Some people choosing something sweet, some choosing something savory. But the idea is that we want to, in the Global Fund, we really want people to have options that will be able to meet their lives. Next slide. There we go. So more about some of the details. I see some people still putting, feel free to continue putting your thoughts in the chat. So I want to go a bit deeper about lenacapavir. So when people think it's just 2 injections and that's it, each 6 months, but I want to go a bit deeper. So there are 2 injections on the first day someone initiates. Those injections can be given either in the abdomen, which you can see on the right-hand side, or they can be given on the thigh. Also, the same day someone is getting those 2 injections, they also take 2 tablets of lenacapavir. It's not normal PrEP, oral PrEP that maybe others are used to. The purpose of these oral tablets is to make it so that you don't have to wait until lenacapavir is effective. So the tablets make it that it's effective very, very quickly. And so basically, during the period of the first few weeks, the oral tablets make the drug levels in your body high enough so that it can prevent HIV until the injections slowly start entering your bloodstream. On the second day, you'll take another 2 tablets, and then you're done with tablets, unless you decide to, unless you're late for an appointment, a couple weeks late for an appointment, or you decide to restart later on after switching to another product. So there's only 4 tablets, 2 on the first day, 2 on the next day. After that, it's just 2 injections every 26 weeks, which is approximately 6 months. There's 2 weeks of kind of grace period in there where you can go as early as 24 weeks. You can go as late as 28 weeks. If you go too late, then you'll just need to start again with the oral tablets. Not a huge deal. Although after 28 weeks, the drug levels might be low enough that it might not be fully effective at preventing HIV. So it's important to understand that, lenacapavir is every 6 months. There are tablets at the beginning, but it's just 4, 2 on the first day, 2 on the next day. Not a huge deal, I think, for most people, especially those who maybe only have access to oral PrEP right now. Again, the injection sites are on either side of the abdomen or on the thigh. I am curious from this group, if you're thinking about where you want your injection. Do you want it in your abdomen, the 2 injections every 6 months, or would you prefer them on your thigh? And if you can in the chat, feel free to put like which one. So maybe the next slide. So you can just put A for abdomen, you can put T for thigh. Happy to hear why you think that. So I see abdomen, I see thigh. So I hear a lot about thigh, of people being used to getting other types of injections in their thigh. My guess is that some people are like me, and maybe I'm not actually used to an abdominal injection, although other things are actually delivered in the same way. So maybe some people are used to that, but for me, it just feels like a weird place. I don't know why. There's no actually like real like science behind my idea. I also think that maybe in the thigh it might be less noticeable, because sometimes it can cause a little drug depot. So it can cause almost like a little pocket of drug that slowly dissipates into the body. And so for me, like having it on my thigh I might not think about it as much. Whereas if I might see myself in the mirror, or maybe I feel it or something like that. So that's important to me. I see a lot of people saying thigh in the chat. Interesting, some perspectives on abdomen being painful. I actually have no idea. And I don't know that we have evidence right now in terms of lenacapavir of whether there really is a difference, in the scientific environment. But I think I would probably be with most people in preferring the injections in the thigh. So if we can go 2 slides, Maria. So what's really cool is lenacapavir is actually a new class of drugs called capsid inhibitors. So what it does is it actually damages the protein shell of HIV and makes it so that it can no longer multiply. And again, in the clinical trials that we've seen results from so far, it's been 96% effective among some groups and 100% effective among others. So super, super effective, which is really, really exciting. And as it is a systemic product, and what that means is the product is actually effective throughout the body rather than locally. So, for example, if someone has if someone uses the vaginal ring, that's a local product. Okay, so it's not going to protect or doesn't prevent HIV from when someone has anal sex, for example. Whereas systemic products like oral PrEP, like cabotegravir, like lenacapavir, they're going to work for nearly all exposures. So we don't have the evidence yet for injection-related exposures for people who inject drugs or people who use hormones, for example, and maybe share needles or share other supplies. But it is anticipated that it would work quite well, given that it's a systemic product. People ask a lot about kind of like, what about the initiation visits, their continuation visits? Looking at WHO's guidance, which is quite clear, really what's necessary is making sure that someone has an HIV test, making sure that if they need PEP, meaning they've had an exposure to HIV in the past 3 days, they get PEP first, and then they can transition to lenacapavir. We're going to check and make sure that there's no signs of acute HIV infection. We're going to look for any contraindications, which might mean that if you know that you're allergic to lenacapavir, for example, which is very unlikely, we're going to make sure you're counseled on all your different HIV prevention options, not just PrEP options, but HIV prevention options more broadly. And then you're going to get those 2 injections on that initiation visit. You're going to get 2 tablets. We're going to give you 2 tablets to take home that you can take the next day, as long as you don't forget. And then we're going to schedule that follow-up visit. After that, every 6 months, you're just coming in for HIV testing, some simple counseling, getting your 2 injections, and scheduling your next visit. It's quite a light protocol and can happen very quickly. 2 injections, some counseling, tablets, see you in 6 months, or maybe see you sooner if you're coming in for another service, etc. Next slide. So side effects are really interesting. So the most common side effects for lenacapavir are injection site reactions, headache, nausea, dizziness, vomiting, diarrhea. However, what is really important is that the nausea, dizziness, and vomiting are actually, in the studies, occurred less for those people taking lenacapavir compared to oral PrEP. They're actually quite uncommon side effects, even though they're among the most common here. If we look at the injection site reactions by themselves, there's 2 that become kind of the most common. One is a nodule. So a nodule is like a small kind of like a lump. It's actually like a drug depot. So it's actually the drug being stored underneath your skin. And so that nodule can form where the injection is given. So from what I've read, they're palpable, meaning that like if you touch it, you can feel it, but you can't see it necessarily. So if you're in a bathing suit and your thigh, or you're having sex and your thigh or abdomen is visible, it's not something that a partner or someone else can see. But if they felt for it, maybe they could feel it. They can last quite long. So you see in PURPOSE 1 and PURPOSE 2, some of those lasted around a year, 10 months to a year. And to remember, you're getting these injections every 6 months if you continue to use it. So there might be periods where you have multiple kind of nodules if you're someone who experiences those. Another injection site reaction that's seen is called induration. That means when the skin tissue around the injection site is like hardened or thickened. So the mean average is about 6 months. The median is about 6 months for people who experience that. But again, when we look at the studies, very few people actually discontinued using the product because of injection site reactions or any other side effects. So this gives me the confidence that while these might be experienced quite commonly, they're not life-changing enough to make someone decide, actually, I don't want to use this product anymore. And I think that's really important. But I do think that people who are making choices about PrEP products and which one they want to use should be made aware of the side effects of each of the different PrEP products, and make an educated decision about what they're willing to deal with. Next slide. In terms of use during pregnancy, there's still ongoing research about use during pregnancy and breastfeeding. In terms of any sort of birth defects, the major birth defects were as prevalent as those in the background kind of prevalence rates, which means if 1% of babies were born with a certain birth defect, that in the clinical trial, there was also 1% that were born with that same one who were not receiving the active drug, meaning seems pretty safe from the data that we have right now. And more data is being collected on non-human animal exposures that also seemed fine. The lenacapavir is present in breast milk for people who are breastfeeding, but no adverse effects were observed. And the levels weren't kind of substantial enough to cause any concern. A question that keeps on coming up is around switching. When the slides are shared, we'll make sure you have access to these 2 links. And maybe if there's a pause later, I can drop those 2 links into the chat as well. But there are insights from WHO in terms of switching between different PrEP products to make sure that they're maximally effective so people don't have as much of a gap. So like if you're using oral PrEP now and you want to switch to lenacapavir, how do you do that so that you're kind of covered and there's not a period where you don't have a PrEP product that's working for you? And I highly encourage this group to look at the training developed by WHO and DPAGO. There's lots of really good information. I think the level of that actually could be used for healthcare providers if you're a healthcare provider on the call. But I think it's also really great for people who maybe don't have a background in medicine who are interested in learning more. So I highly recommend looking at that as well. Next slide. So I'm curious, now that I've talked about some of the more of the details, where the injections are, how many there are, taking the 4 tablets at the beginning, some of the side effects. I'm curious if anyone could put in the chat, like, would you change your decision? So maybe you chose oral PrEP before, and now you're like, no, I'm team lenacapavir. Or maybe you were interested in lenacapavir before, but now actually you're more curious about cabotegravir or the ring. Anyone can kind of give some insights into whether you changed your mind. So Lizzie is now interested in oral PrEP. Anil is still very keen on lenacapavir. Ruan made no change. I'm trying to remember what Ruan decided earlier. Okay, Ruan was team oral PrEP at the beginning. Other people saying not changing. Looks like maybe Austin changed. Okay. So this is the reason, actually, this is a great example of why it's really important that people who are considering these products get information about the product so they can make an informed decision that's based on kind of their values, their needs, even their fears or misconceptions or preferences. So that's really important. Great, thanks. Next slide. So do we want to, Lizzie, you tell me, or Maria, do we want to take questions now on the technical piece and then get into more of the kind of global fund approach?
Maybe we should, I was thinking we should do questions at the end for both. What do you think, Chris?
Yeah.
Okay, cool. So we can do that. Feel free to put other questions now that you know what I talked about. Feel free to put other questions in the chat, but I'm going to go more into the global fund's kind of approach on lenacapavir. So what we know is that right now, new infections have been decreasing in most countries. So I say in most countries because it's really important to recognize that there are some countries where new HIV infections are increasing. There are also populations within countries where reductions in new HIV infections are not happening at the same rate as other populations. So what this often happens is when a population is stigmatized or ignored and they don't get the same level of services as others, right? However, what we want to see is we want to see a move towards the 2030 goal of having HIV no longer be an epidemic. And so we see that lenacapavir is coming at an amazing time. I mean, although we would have loved it 25 years ago, it's coming at a really great time in order to kind of further leverage the impacts that other PrEP products, that condoms are having, that other prevention products are having, that treatment access is having on reducing new infections. And we want to see that lenacapavir is part of that, right? And so the progress that we're making right now is really fragile. Lots of things are happening in the world. And so we want to see how can we actually leverage lenacapavir to make it really accessible to people to further kind of drive down new infections. And provide people with an option that works for them in their life. Next slide. And so in November, December of last year, the Global Fund, said that we were committed and we remain committed to reaching 2 million people with lenacapavir between 2026 and 2028. 2026 is remarkably close, and so we've got to get started on that. And so we have worked across the partnership over many, many months in order to figure out how can we, with not unlimited resources, best support introduction in a different way. For those of you who've been engaged with PrEP introduction in the past, it has taken too long. Simply, it's taken too long to reach the people. It has taken too long to reach the scale that can have impact. It has been not equitably accessible. And we see that in the US, PrEP became available in 2012. However, there's still countries that have no PrEP program where it's desperately needed. And so we actually really set out a new ambition when we were looking at lenacapavir, given the promise that it holds. And we said, we want to introduce lenacapavir at the same time as it's becoming accessible in high-income countries. We didn't want there to be any light between access in the US or Europe and access in places where it is needed most desperately to really create change. And so sadly, we have limited resources. Even though we are the Global Fund, we do have limited resources. And so we had to think through, well, how can we do this differently? And part of that is making sure that we can actually introduce quickly. Introducing quickly has a number of benefits. One, it immediately begins to have impact in the communities where it's accessible. And two, it creates a large market for generic manufacturers to actually be able to enter into so that they can actually have huge volumes and they can reduce the price and make it more sustainable. And so we worked across the partnership and across a number, and like working with communities and a number of other stakeholders to kind of understand which countries could probably launch really fast because they've done it before, could have a high impact because there's an important need that needs to be met. And so it was established that, we would look at a set of 9 countries and we would see how can we encourage and support these 9 countries to be able to introduce potentially before the end of this year, but within the first 3 months of next year. And it's been really, really amazing that each of these countries has committed to introducing lenacapavir before the end of March of next year. Some of them are saying we want to introduce by the end of this year, which is absolutely remarkable. And it's really, really exciting to see the movement. I think in the past, for those of you who've been engaged in PrEP introduction, there's been lots of like, oh, we'll do a 100-person study here and a 100-person study there, this pilot. And then what ends up happening is you have 2 or 3 years until people actually start to be able to have access to it. And so we kind of changed that with this approach, and countries were willing and excited to move in that. And part of that was the demand of countries. So we're really excited about being able to support these countries. We're also really excited about being able to expand this list of countries. And when a number of factors kind of fall into place, including resource availability. Again, the Global Fund, unfortunately, is not an infinite amount of funding that we have. And not every country is ready to go immediately. And so we're really excited to be able to support countries when the different kind of stars align that allow us to be able to meet the resource needs with countries, and also when countries are ready to kind of move on their own pace. Next slide. So in terms of the next step, so those 9 countries have all said they want to introduce by the end of Q1. Again, if you are looking for introducing by the end of this year, some countries have already developed a plan. Some are working on plans alongside their grant cycle 7 revisions, which are due September, October of this year. We gave advice to countries on budgeting. Essentially, how this works is that the Global Fund has centralized funds that will be used to offset the full price of lenacapavir. So countries will only have to pay for a certain portion of the actual cost of lenacapavir from their grant budgets. We also have a number of TA providers that are ready to support countries, which is also really exciting. Those have all been communicated to countries themselves. And then we're working on with across partners to develop a number of materials such as like template guidelines, trainings, etc., and have emphasized again and again the importance of community engagement throughout the process, not just at the end, not just at the beginning, but throughout the kind of process of planning and introduction, because we think that there's a lot of places where community engagement can make the programs better. Next slide. Oh, that's it. Perfect. Go back to some questions.
Yeah.
I see there are 2 in the chat already, but Lizzie, I'll let you manage the question.
No worries. We can just pick it up. And I just want to defend myself. I only changed it after landing. So I was excited about LEN being available, but I didn't have a lot of data. So now that I have a lot of data, I've changed my mind. But we do have Josie. Josie saying lenacapavir price can be reviewed lower and available in every country. Is that the case?
So the Global Fund we have an agreement with Gilead, who right now is the only manufacturer. And that allows us to access a single price across, I believe, 120 countries, all of which are included in the voluntary licensing agreement, which is public. And I'll try to maybe later drop that into the chat so people can see all the countries. But that price is available to, all of those countries. However, the challenge is that we have limited resources. So right now, the focus is on kind of getting these 9 countries up and running, and then exploring how can we expand access to that lower pricing again. A big part of this kind of move quickly and move big approach that the Global Fund is taking is so that generics can actually come in at a much, much lower price. And we seem to have good signals from generic manufacturers. Gilead has set up 6 voluntary licensing agreements. So meaning that there are 6 manufacturers that can make the drug, and they can make it for that same set of 120 countries. That will create competition among manufacturers that should be able to drive down price, and the volume should be sufficient enough that the price can be sustainable. And so for some countries, perhaps even many countries, they might wait until lenacapavir is available from generics, which we expect in 2027, perhaps even earlier. So they might wait until that happens in order to introduce and scale up lenacapavir. What we're all hoping for is that we can see lenacapavir moving in the direction of oral PrEP pricing. However, there's lots of benefits that countries have and individuals have in terms of its fewer HIV testing, its fewer clinic visits, like all these things have kind of wider health system impacts that can actually reduce the kind of total cost, because the cost of lenacapavir, just like oral PrEP, is not just a product, it's all the other things kind of that are associated with it.
Yeah. And I know George asked, how would you manage advanced or extreme cases of side effects from LEN? And I know some questions also coming in, but before you answer that, maybe we can get Anil to unmute and ask his question. Anil, over to you.
Thanks so much. So the question, first of all, thanks, Chris, for that really, really useful presentation. The question I've got is really on the role of communities in all of this, because learning from our previous experience of rolling out PrEP, we know there was a lot of time wasted with ineffective strategies, and we really don't want to repeat that. In a lot of countries, the first time we started to get traction in terms of access to PrEP for key populations was when we started having community-led service provision and access via safe spaces. Now, a lot of those community clinics and key population clinics around the world have closed down due to funding cuts. And if we're going to try to roll out without those safe spaces, we know we're going to have the same barriers to access over and over again. So I just wanted to hear a bit more of your thoughts on the role of communities, not just in kind of as an added extra to make things better, but really central to ensuring access, particularly for marginalized communities. Thanks.
Yeah, I'll say one point, and then I'll maybe hand over to Maria to speak more. one thing I think that has to be done, because one part is we have limited ability to kind of influence kind of like those platforms where PrEP was previously provided are now missing. That's an area where it's difficult for us to influence. One thing I think that is really important is how can we look at other ways to make PrEP more accessible to key populations, and one of those that a lot of countries are actually adopting now is looking at how can we like eliminate all these mentions of key populations in guidelines. Like how can we eliminate that people have to identify themselves as part of a certain group in order to have access to a product or have to disclose certain behaviors. And that's something that we're working on kind of like as we support countries to kind of say, hey, let's not say that, you know, lenacapavir is only for sex workers. Let's actually change that, because a lot of people can't say that they're a sex worker. So you're actually limiting access to the people that you want to have access to it the most. Some of those things are going to have to be policy wise, but I think one of the other aspects is that we, we're actively engaging a number of donors and to like kind of support communities. And maybe I'll leave Maria to kind of to add on.
Thanks, Chris, and thanks, Anil. And yeah, no, I really agree that, you know, the role of communities is absolutely central, and it's beyond community engagement. It's really about community systems and responses. And I think in the opening stage, we talked a little bit about some of the examples that we might hear from today, but also, you know, we've really been trying to show across the spectrum of product introduction that community engagement is important in all of these spaces, but also in terms of systems and responses. So that could be the adaptation of community-led monitoring to ensure that services are acceptable and quality and non-stigmatizing and KP competent, and all of the things that we know are going to be really, really important in terms of access to all prevention, actually, including LEN-PrEP. I think it's also going to be important that we work together in terms of making sure that it's clearly understood that lenacapavir can be delivered at the community level as well as in other spaces. And I think that's something that we also want to continue to talk to you all about in terms of really good practice and what works well. But I think this is something that both Chris and I have been discussing through this whole process. And yes, as Chris mentioned, we're also working with other partners to ensure that there's a clear awareness of the planning around LEN-PrEP from our side, and what can be done in terms of funding and also other resource support for communities in terms of this whole kind of piece of work that kind of goes beyond the Global Fund, because of course this is kind of a full partnership approach. So I really appreciate the question and the comment, Anil, and I think we need to keep highlighting all of these issues as we go forward, because there's a lot of lessons to be learned, as you say, from previous product rollout, and we're, as you can see, there's an ambition here that we need to move forward on, and we want to take all of those lessons with us. So really appreciate it, and we can continue with the conversation. I see there's a number of other questions, so I want to make sure that there's time for those as well.
Yes. Yeah, so I think we'll skip to the next beat, but Chris, Maria, if you guys can also type the responses to the question. I've seen a couple of them trickle in. That will be awesome. Simon and Cecilia, we will take your questions, but after the second session, also my apologies about that. Maybe Maria, you can stop sharing the screen. So as we mentioned, that was just the first beat of the discussions. We do have now the community's perspective, where we listen to, you know, some of the community's speakers on community priorities and learning exchange. And we're going to have Jacqueline from Uganda, Gloria also from Uganda, then Cyprian from Tanzania, and Simpiwe from Eswatini. And I'm excited because Simpiwe, I saw out of the 9 countries, Eswatini is one of them. Jackie, real quick, before we pick the next round of questions, ladies and gentlemen, we'll just have Jackie. Jackie, are you on the call?
Yes, please.
Yes, I'm just going to share my screen.
Everyone.
Hi. So Jackie, I'll just share my screen. My apologies, 1 minute. And then you can kick off. Over to you.
Under community perspectives on LEN-PrEP, you have displayed best practices, but I would love you to help me display the community perspectives on LEN-PrEP. because when I had and I was getting some of their decisions and some of their perspectives on LEN-PrEP. So
will that be at the beginning or at the end? Okay.
This is just it is in the middle. It is
Just let me know
after
when to stop. Yes, there it is.
Yes, please. Thank you. The next slide. Next slide, please. Yes, thank you so much, Lizzie and team. Under community perspective, we have high enthusiasm and hope. There is really a lot of hope down here in the grassroots. I am from Uganda, Eastern Uganda, and I'm leading a key population-led organization, an indigenous organization, and we are engulfing all the other types of key population because currently we are the only ones implementing in Eastern Uganda due to the funding cuts. So we're implementing under CDC. So I collected some of our community perspectives in different DICs of our key populations. And I also went to antenatal rooms and collected some of the perspectives of breastfeeding and pregnant mothers who are in a discordant relationship. And I found out that there's really hope. They really need the PrEP lane. They have not yet known much about it, but I tried to explain to them, and they really exhibited that it would be much more convenient to them than using the tablets. So their concerns about side effects and safety was on lack of clear information on the long-term effects. They are thinking of maybe there would be effects that they are not telling them. So they really needed a clarification about the effects. So there is also fear for needles. We also have those who fear needles and injections, but those were just a few cases. So there is also concerns about drugs, about drug interactions, especially for the trans people. Yeah. So next slide, please. Next slide. Yeah, they also were betting on access, equity, and cost issues. They were asking how much it would cost. That is a question that needs an answer. And also they were thinking maybe it is for specific category of people, but I really informed them that it's for the key population. And also it will also be available for the breastfeeding and the pregnant mothers. And it will be accessible in our different facilities. So there was also low awareness and need for education. Yes, they are actually not aware so much about the PrEP, the new PrEP lane. So there is really need for much awareness, create dissemination of information about this PrEP, and also creating awareness and sensitizing people on this, especially using health talks in the DICs and in the facilities to inform them about the uses, the different use of this PrEP lane and how effective and convenient it will be. Next slide. Slide, please. Tailored needs of key population. Yes, we realize that there is a lot of needs of key population that needs to be tailored. It needs to be tailored, especially the sex workers, the young people, trans community, and they will, with this PrEP lane, it will really be convenient to them because they have been complaining so much about the tablets and the packaging. So with this just injection of 6 months, because this is really what they want in my side in Eastern Uganda, they really want the PrEP lane, the LEN-PrEP, the one that is taken after an injection in the thigh or abdomen after every 6 months. Thank you. Lizzie, can we go to the next slide? The next one on, yes, there is need for call for community involvement in the rollout, really. We need the community at the point of the rollout, really. They need to be there. They need to know, they need to make a decision. So best practices that they came up with, there is need to develop a much more comprehensive plan Then training and capacity building, that one, it has to be at the point of enrolling the LEN-PrEP administration and management. Then we need to continue with monitoring, awareness creation, integrating with other services. Right now, we are speaking about integration at every point of healthcare service provision. There is need to integrate. So lessons learned, there is need for continuous evaluation and reflection. There is need for stakeholder confidence and skills. They need the skills to take up this PrEP and manage it and help administer to the specific shaping engagement priorities for HIV prevention. Next slide, please. Under shaping engagement priorities, we have to prioritize key population. That is what I think must be done first, because this is the population that is mostly at risk so much, and basing on their ways of their sexual life, they are at risk. We are at risk. So there is also need for community-led and community-owned responses. Yes, we need to own this. We need to own the LEN-PrEP intervention, and that will help us engage our peers. It will be peer-led education, counseling, and outreach models. So expand access to prevention. Yeah, there is need to expand access to prevention of pre-exposure prophylaxis, and also incorporating other measures of prevention, including condoms and lubricants, and also self-testing kits. Next slide. Then we need to utilize digital platforms and social media. Yes, we really need to utilize more digital platforms to create awareness, to reach out to the hidden most at-risk population, the unreached population. We really need to use the digital platforms. The next slide. Strengthen health systems and service integration, which I've already talked about in the best practices. We need to train service care providers and integrate all HIV prevention services into our day-to-day activities. Combat stigma and discrimination. This one is always there. So we need to do away with prejudice against PrEP, build partnership and collaboration with community CSOs and healthcare providers and other stakeholders like government and districts. LEN-PrEP offers a promising solution for HIV prevention with its long-acting injectable formulation that is not only convenient, but also with high efficiency in protection against HIV/AIDS. Therefore, this medication can be recommended for all persons who meet the eligibility, and as long as they are at high risk of acquiring HIV/AIDS. Thank you so much for listening.
Thank you very much, Gloria, for that. I was about to tell you your 5 minutes were out. But thank you very much for that insight. It's always good to know that you actually have been speaking to them and you're giving them the right information. Gloria is here from Uganda. Also, Gloria, over to you.
Hello, yes, thank you so much, Lizzie. Can you hear me?
Loud and clear, yes.
Perfect. Good morning and good afternoon, everyone. My name is Nawanyaga Gloria. I am from Uganda. Liz, is it possible for me to share my slides?
But you only have 5 minutes if you're going to share your slides. Sure.
Okay, I'm
sure.
going to, yes, I'm going to summarize. Okay.
Great. Perfect.
Okay, thank you so much. Once again, my name is Nawanyaga Gloria. I'm a Global Alliance Equality Champion from Uganda with UNICEF, UNAIDS, and other development partners, where we are advocating for children and making sure that priorities of children are put at the center. I'm also the founder of Gilo Young Posties Foundation, which is a youth-led charity organization where we do empower, equip, and educate young people to improve their livelihoods. I'm also the aspiring youth MP Central Region. So my task was very, very easy or simple. I'm just going to talk about the key considerations when it comes to LEN-PrEP rollout. And since I have 5 minutes, allow me to be very, very fast on this. So what do communities need for successful LEN-PrEP rollout? First of all, I want to appreciate the first speaker, the first presenter who exclusively educated us about the LEN. And for us, it is a game changer for advocates, but then also as people living with HIV, we are advocating for LEN for treatment because we are also tired of the daily pill. Just like people are complaining of the daily PrEP, oral PrEP, we are also tired of the oral treatment. So we need the lenacapavir for treatment. All right, we need awareness and culturally sensitive education, since most people are not aware of the lenacapavir and they're still actually confusing it. Is it the cabotegravir? Is it the normal PrEP that people have been taking? Is it the lenacapavir for treatment? So there is a lot of confusion. So we need to make more awareness. We need to involve community leaders and peer educators and also health workers so that they can be well equipped and well educated about the lenacapavir. We need accessible clinics and outreach services. With all the funding cuts, we have had limited access. Now that some in Uganda here, we are prioritizing integration, and we understand that we had art clinics which were literally closed. And this has limited access to clinics because we have been integrated with the public or the OPD, where where health workers are already overwhelmed, there are already huge numbers. So young people and people living with HIV literally are finding it hard to go to the OPD, the general clinic where there is health services, and make lines and all that. So it's limiting access, and would really appreciate if there is more accessible to our own treatments, our own clinics that were there before the the funding cuts. We also need trainings. I think I talked about these trainings of the healthcare providers, because most of these actually also don't know. They are confusing it with cabotegravir. So there is a lot of confusion between lenacapavir and cabotegravir. We need to educate them. A reliable and sustainable supply chain. It is. I'm glad that Uganda is one of the 7 countries where Global Fund is going to, start with a rollout. But as third world countries, we have always advocated for reliable, but then also affordable treatment, but also the new products in prevention. And I'm glad that Uganda is one of the countries, but also we have to expand to most third world countries to see that they they have these products, and these products are accessible, they are affordable, and they're also available in those countries, because most of these countries are where the high populations, that's where the high prevalence of HIV is. So systems and structures for fair access, we need equitable distribution policies. We need guidelines and policies that can help in equitable distribution. That is, of course, falls under accessibility, availability, and affordability. We need decentralized delivery models. We need financial support and subsidies. And I'm glad Global Fund said that Gilead is one of the, the only manufacturing company, but also it has helped in subsidizing or reducing on the, on the rates of the cabotegravir purchased right now. And we need more of the financial support. I understand there is a financial crisis, there are funding cuts and all that, reprioritization, but we still need the financial support. Now, we also need the data systems to track inequities. Someone said that we should not associate lenacapavir to sex workers, But these are some of the things that, you know, can help in when we talk about key populations. Oftentimes they are left behind. So we need to include them and make sure that they actually own a part of these initiatives, because if we leave them behind, I'm not saying that I acknowledge your point, and I'm not saying that we should entirely associate it only sex workers, but we need to also associate them with these products so that they can, you know, feel that these are their own products, these are products for them, and they are not left behind. Integration with other health services, and I know most countries are adopting integration. Everyone is saying integration and integration. So I think this is a good opportunity to see that lenacapavir is integrated with other health services. Building trust and reducing stigma. Let's normalize LEN-PrEP as part of sexual health, SRHR. Let's use community champions to share experiences. And
Yes,
I think
and also just to
Uganda,
give you a heads up, you're running out of time.
yes, this is actually my last slide. Yes, so I'm glad Uganda, I think it's one of the countries that had the study research on LEN. So we should use already champions who have experience in using LEN to put the information out there. Let's address the myths and misconception. And I already talked about the confusion between lenacapavir and cabotegravir. Let's also ensure confidential and private services, create inclusion messaging for diverse groups. And thank you so much for listening to me, and I'll be happy to answer any questions if there are any. Thank you so much, and back to you, Lizzie. Hello? Can you hear me?
Yes, I can get you.
Okay, is Lizzie on? I think I'm done with my presentation.
I think she dropped. Let's wait.
I think she's frozen.
I think you can come in for your presentation. Yeah, I think she has an internet issue, but you can come in. The next presenter.
Yes, I think we can have Cyprian from Tanzania. Thank you so much for listening to me.
Okay, thank you so much. I think I'm audible. I don't have a presentation, but definitely I'll talk from the word of mouth based on what I've corrected to the people that I serve and based on what I've asked them on the issues around lenacapavir and lenacapavir comparing to the oral PrEP that we used to here in Tanzania. I think before we move into the lenacapavir, we need to be sure that the challenges we experienced with the oral PrEP, especially around the policies and guidelines, are properly addressed. I'm sure that we all know that, and we acknowledge that the lenacapavir is really a game changer for the HIV prevention. But if we do not fix those systematic gaps, we risk fading back into the business as usual, where the new tools is available, but the communities can't full benefit from it. I'm just giving an example of what I've experienced here in Tanzania, that we had the oral PrEP, and then we were implementing oral PrEP in a different places here in Tanzania, but definitely we were not allowed to do some things which are very potential for the community that we are serving, particularly the key populations. For instance, we are not being allowed to talk about PrEP on social media. So we are not allowed to just create awareness to the community that we serve through the social media, through the internet, through the radios, through different platforms that we could have reached we could have reached the population in need of the services through the media outlet. So this was strictly prohibited. So systematic gaps like these ones and other structural gaps need to be addressed before we go to roll out this what we so-called lenacapavir. From the community side, our priority are clear. First, the policies and guidelines must be updated early and made it inclusive so that young people, women, key population, and every other population, including those in the rural communities, are not left behind. And second, the service delivery need to go beyond health facilities, using the mobile outreach to just reach people to understand where they are and what do they need. Because all of those services, we could have not seen them are happening in my country, and I'm giving a clear example of what is happening in Tanzania, and based on the consultation I made with the people that we are working on the ground, but also the community we are serving on the ground, they would request to see that whatever we're going for the lenacapavir, we know it's injectable, We know it has to be offered through the S facilities, but we need to see that the outreach programs are also happening to see that we just get communities where they are to deliver those services. And the peer-led approach needs to be also emphasized, that because we know if we will implement the peer-led approaches that people trust, we will also need the healthcare worker sensitization to tackle stigma, strong investment in the community literacies and demand creation so that people understand and they trust LEN-Capaville. And finally, but not the least, community want to be part of the monitoring and accountability of the LEN-Capaville, because we have seen during the LEN-PrEP, we had the community-led monitoring that we monitored how do we implement our PrEP, but we were restricted in a one way or other to just be full engaged in the processes, and the other, as I mentioned earlier, that we were not given an access to just understand what is really happening on the programming part of it, but also being part of the real implementation of the programs rather than the recipient of the services. So I would love to see that as a community, we are the implementers, we are the co-implementer with the government of the LEN-Capaville rather than being the recipient of the services. But before we go for all of those that I've mentioned, because the LEN-PrEP has gave us a lesson to just understand that there's a guideline, there's a policies failed us in one way or other. It's now very clear for the Global Fund, for the team to just do an assessment to understand those policy gaps, those guideline gaps that hold us back on implementing fully the LEN-PrEP are addressed before we go for the LEN-Capaville, because if we go for the LEN-Capaville without addressing those issues, definitely, as I said earlier, we're going to go for the business as usual. So this is what I've got from the community that I'm serving. Thank you so much.
Great. Thank you very much. I don't know, Cyprian, if you can hear me. My apologies. Today, my network is just not on my side, but thank you very much for that input. It is good to also see that there are a lot of issues that communities are facing. And, you know, right now, we really
think we may have lost Lizzie again with her network problems. I think we had one final speaker in this section from Eswatini. If you're here, do you want to go forward, and we'll see if Lizzie's able to join us again?
Yes, I can go ahead.
Thank you.
Well, afternoon again, colleagues. Thanks for the great opportunity to present in this platform. I hope I'm audible. I'm Simphiwe Makanya from Eswatini, representing the people who inject drugs community and outreach worker at Help Plus for Men. Well, I have a few points outlined for the presentation. Well, point one is we await rollout. Point two, there's a need for training for peer educators. Point six, point three, the 6 months is convenient for people who inject drugs since they are high new infections and high interruption on ART treatment, and there are challenges with adherence and seroconversion. And the last point will be creating access and demand. Can I just briefly go through the points? Well, point one, as communities and the country at large, we are still awaiting the rollout of LEN-PrEP, since it's fairly a new concept. We were just getting accustomed to Kepler-PrEP and have been actively educating peers at community levels, creating demand through hotspot-based risk reduction community sessions. Well, the second point, which is need for training for peer educators, there's a very enormous need for the trainings for peer educators to learn more about LEN-PrEP. I was privileged to attend few sessions on LEN, but there are still gaps since the other outreach workers have not received such sessions. And those sessions were on side effects and withdrawal requirements when transitioning to daily PrEP. Therefore, such information is critical for our clients to understand before they initiate on such PrEP exercise like LEN-PrEP. Well, the third point will be the 6-month convenient for people who inject drugs. Since I think since LEN will be, sorry, have you got something to say?
No, carry on, Cynthia.
Can I continue?
Yes, please. But your 5 minutes are almost
Oh,
up.
okay.
But
I
please
was
continue.
on the 6 months will be convenient. My time is almost up. The 6 months is convenient for people who inject drugs. Since from experience, the daily PrEP had not been working well for people who inject drugs. And we would forget to take medication. Some would use it to cut the opioids, opinions, and managing that as a peer educators, it would be very difficult. Most people who inject drugs are already HIV positive, and there are closed limit cycles due to delays in such innovations. And there are seroconversions taking place from this community. Well, my last point will be demand creation and access. Besides the rollout, which is plotted in a few facilities, I foresee a challenge for people who inject drugs accessing LEN-PrEP, as the only friendly clinics and mobile clinics outreach have been closed due to the US fund withdrawal. So they were usually able to access such services at community levels, which would be reached out like with mobile clinics. But due to the withdrawal of the funding, clients are accessing services at facilities of choice, and they are very reluctant to go to facilities of choice. So we would really love the Global Fund to kindly give us again mobile clinics at community levels for our group to be able to access the services at community level. Thank you.
Thank you very much, Cynthia. We really appreciate it. That was quite comprehensive. And I really understand that we do have a lot of legwork to do. Ladies and gentlemen, as I mentioned, this is an English run webinar, and it's going to be it is actually translated into Portuguese. So if you've seen the globe icon on your phone, Rui is on the other side translating it. Of course, we do have somebody is sharing their. Richard, is that you? There's a screen being shared. But ladies and gentlemen, this is the part where I like most. We've been speaking, but then we have the opportunity for you to also address some of the questions or concerns or even comment. I know, and Cecilia was on the call, and I don't know whether she's dropped off. And Cecilia, if you're still there, we are opening it up for Q&A.
Okay, so thank you very much, Lizzie, and thanks to the presenters. Very great presentation and insight. My name is Cecilia Senu, board member of the Global Fund. I also work with Hope for Future Generations, a community-based national NGO in Ghana. And so the insight and the presentation has given a lot of information. So I wouldn't like to ask, because Anil a number of people have asked that question, including Anil. And what I just want to say is that our delegation has been advocating for this PrEP. I remember the board meeting in Africa last year, we pushed a lot for this, and we never knew Global Fund would be doing this. What I would like us to also take into consideration is to ensure that we engage community-based organizations across the regions that are going to be implementing this. And I know many of our countries will definitely join the 9 countries that Global Fund is going to be piloting it. And also to just reiterate the involvement of communities and civil society in this implementation across the countries, to be the eye and to be the voice for this. So thank you, Lizzie, Yanaso, and all of you for this. Thank you. Over.
Thank you, Cecilia, of course. And we're super excited about this breakthrough, but we also want to just make sure that we kind of let the communities and civil societies understand what LEN-PrEP is all about. Ladies and gentlemen, as I mentioned, it's the Q&A session. If you do have any questions, feel free to raise your electronic hand, but we really appreciate the speakers who've spoken. We're more concerned about, so I'll even ask this question to Maria and Chris at the beginning. We're talking about 9 countries. It would be amazing to see if we have, we move from 9 countries in Africa to at least 40 countries. You know, that would actually really help with the fight against HIV/AIDS. Yes, and there's a quiz that's ongoing on your screen, so please feel free to just answer those 4 questions. We're trying to see if you already understood or had prior knowledge to what lenacapavir is all about. Rhoda Lewer, I've seen you. How are you doing? Please do unmute and ask your question or make your comments. Over to you.
Thank you, Lizzie, and thank you to all the speakers. All is well. Mine is a comment, which is based on observations that a number of countries have not embraced community-based dispensation of biomedical commodities such as lenacapavir or even ARVs. So when we are talking about community-led or communities involved in implementation and delivery of lenacapavir, this really has to be well thought out. I think there's a colleague from Tanzania who talked about the policy guidelines, and at policy level, it has to be really broken down in terms of exactly what and how communities are going to be involved. And there have to be models, because there are countries where TB and malaria medicines are not dispensed at community level. You have to go to the health facility. So in such countries, what model then will be best for communities? So it will be good for different models to be developed for where community-based service delivery of biomedical commodities is already happening, but also for where we don't have such models allowed by health policies in those countries. Thank you.
Thank you very much. Yes, Rhoda, that is true. There are a lot of things that we need to look into. We don't want to get to a point where we are calling out Chris for lenacapavir, but then the demand is not there. So we do need to look at a lot of aspects. It's from a 360 degree. And I appreciate what worked, because during COVID, we used, some of the HIV interventions just to make sure the vaccines get out there. I'm also curious how we're going to make sure that lenacapavir reaches everyone. Chris, over to you. I know you've been overwhelmed by a lot of questions on the chat, but thank you very much for just also looking into them. So over to you for some input on that.
Yeah, in terms on, I think there's 2 things. So one, I want to talk about the country piece, because I think that like, Lizzie, I think you said 40 countries. Actually, the Global Fund, I think, has HIV grants in 103 or 106 countries. I would like to see it available in all of them. I think my frustration is that we're coming up against a problem that we have again and again, which is that we have the tools, but we don't have the funding and the resources to make it available to everyone who needs it. And that continues to be one of like our biggest downfalls, right? Like the Global Fund, yes, we support countries and a lot of countries with a lot of money, and yet it's still not enough, right? And so I think that's one is my vision, right? I would love to see 106 countries have access to this product tomorrow. And unfortunately, the reality is that that's not where we are. Where we are right now is we're trying to understand how much can we support within these 9 countries. And then from that, like how much more can we support? And who can we, and like we're working very actively trying to get people to give more money to be able to support wider scale up. But unfortunately, the funding is really just a limitation. And that's from centralized funds to country grant funding. And the reason why we are, and it's really frustrating for us, it's frustrating for other countries that want to access it, it's frustrating for communities who want it available everywhere, right? And so I think the reality is that until we have further resources to be able to expand access, until we have a lot of generic manufacturers on the market where price is lower, it's not going to be available everywhere, unfortunately. it's not going to be super easy for everyone in a country to get, whether they live in a rural area or an urban center, right? And so, that's why in working with countries, we're saying, how can you get it to where it's needed the absolute most? We know that like there's going to be people everywhere who need it and want it. But unfortunately, we just don't have the resources to be able to do that. We unfortunately, we don't have the funding to be able to do mobile clinics for every single kind of remote area, or some countries are not willing to allow trained lay workers to be able to deliver this medication. One thing I'm researching right now is measles vaccines is actually a very similar injection to lenacapavir. And so I'm trying to find examples where countries have allowed for this to be done for other disease areas, where we can say, hey, no, look, these countries did it for measles. It's very clear that if you give someone quality training, they can deliver this product, so that we can address some of these kind of like more rural areas. But I think, at first it's going to be that countries are going to probably start with urban centers. They're going to start to, and focus in districts where there are the most numbers of new infections, where it can have the biggest impact the quickest. They're going to focus on how to make sure that populations that need it most have access, perhaps before populations where their chance of acquiring HIV is like 1 in 10,000. And so we hope that countries will focus it where it can have the biggest impact, until we have more money available to go bigger, and also until we have a price that's lower that can allow us to do more with the money that we do have. But yeah, it's tough, because I think that all of us on this group, in this discussion right now, we all want the same thing. We want everyone who wants access, who needs access to it, to have it. But unfortunately, we're still in a situation where resources are limited. And so we're going to have to continue to push for more resources. That's what we're doing at the global level. That's what we're hoping that countries are doing. That's what we hope that advocates and activists are also doing at their national level, saying this is important, make more money available for this. But we'll have to continue working across the partnership to figure out what we can do, and making sure that countries and communities remain at the center of that work. Yeah.
Yeah, I hear you, Maria. I don't know whether you want to add on, or
No, I
we
think
just carry on.
covered everything quite beautifully, but only to add that I particularly appreciated the examples and the of the previous speakers in relation to some of the community-led and based responses that have been effective. And I think some of the areas that I noted down that were especially important were around utilizing and training peer educators, ensuring that differentiated service delivery remains as part of this, as part of the rollout, the key role of communities across the whole spectrum of introduction, and not just in terms of engagement, but also in terms of service delivery strengthening, and monitoring and evaluation, creating those feedback loops through CLM and other mechanisms of accountability to ensure that that we can keep honing and maintaining access to those services. I know that Chris has dropped a number of links in the chat in terms of really helpful resources, but we have quite a few more. So what we can do after this, if it's okay with you, Lizzie, is we can send you that list to send to those who attended this call, because there's a number of, I think, excellent training materials, the WHO guidelines, lots of, and also examples of models, as another speaker mentioned, which I think would be quite helpful in terms of moving this conversation forward. But back to you, Liz.
Great, thanks,
Just put
Maria. Yes,
links
and I really
again in the chat, just so people can get them. There's a couple that I think are really cool. One is like one that shows the comparison between the different PrEP products, and I highly recommend people like go there, download that, share with your friends, share on WhatsApp, share wherever you can, because I think a lot of people maybe learned from the beginning part of the discussion today, and so I think raising awareness will also drive demand and help people have a stronger voice. I'll go back and find those. Sorry.
Great. Thank you very much. I know we're coming to a conclusion to this particular webinar. I really appreciate the input that has been given. As Ian now, so I'm going to let my colleague actually type in an email address that you can use to register or get our newsletter updates. We will be sending a write-up on this particular discussion and share all these links with you. So if you're not already subscribed to our newsletter, please do that. And of course, as the Anglophone Africa Regional Learning Hub, we want to share as much of the information that we get, and especially the ones that are trickling from the Global Fund with the communities and make sure we're on the same page when we're talking about lenacapavir. So ladies and gentlemen, if you missed the first part of the discussion, do not worry, we will share the recording and all the links that Chris has also been sharing with you and hopefully some of the presentations that were made. We have 6 minutes, so I'm going to hand it over to Maria because I was doing a quick glance to see if there's any hand up. There's none, so that's a good sign. So Maria, just over to you to close up. But ladies and gentlemen, it was great having you here. We had over 130 people on the call. We still have 104, so then that means this was really a discussion that we really needed to have. Maria, over to you.
Thanks so much, Lizzie, and thanks again all. I won't repeat what we've already said because I feel we reflected some back in the last few moments, but I really appreciate the rich conversation, the examples, the intelligence and the feedback that you've provided in terms of all areas of product introduction. And I also appreciated the conversation in relation to what is LEN, what is not LEN, what are your preferences. I think it was very insightful. I think what I took from it is that, you know, we need to continue to provide that kind of information. There's still many questions in relation to LEN-PrEP, particularly in relation to side effects. What does this mean for people? And I think this is something that we can continue to feed back internally as well, because it's clear that we need to keep providing clear and unbiased information in relation to what this product is. I also really appreciated the focus on community services, and what we heard very, very clearly is that those strong community systems that need to be in place have been so critical in relation to other product introductions. So I think that was very clear, and I think the examples from across the countries was helpful for me, and I hope for you all as well. And I think we'll continue the conversation. I'm sure Lizzie will do another of these webinars at some point in the future. Thank you very much for it. And we'll be sharing afterwards in terms of the resources and the other links. Thank you.
Thank you, ladies and gentlemen. For once, this is the first webinar I've moderated that actually returned 4 good minutes back to you. I'm usually asking for 10 more. So thank you very much. I highly appreciate your time. It's been quite intense. We've been talking about LEN. Don't worry, this is not the last conversation we're having. As I mentioned, Ian Nassau under the Regional Learning Hub will be hosting more discussions like this, and also in collaboration with other regional learning hubs on behalf of the Global Fund. For now, I say thank you very much. Asante sana, and have a nice day, a nice morning, wherever you joined us from. Goodbye.
Bye.
Thank you so much. Bye.
Bye.
Thank you.
Bye. Thanks, Lizzie.
Thank you. Goodbye.